Hello and welcome to another POCUS ultrasound presentation. This one is on giant cell arteritis. Okay, giant cell arteritis, GCA. This is also known as Horton's disease, cranial arteritis, or how I learned it, temporal arteritis. All right, so we have these temporal arteries. They come in front of the ear, and there's branches that branch off. And how temporal arteritis, how I was taught, is headache, and you see a thickened erythematous artery in the temple, and that's how I was told to screen for it. But of course, we're going to go into more detail today and tell you how ultrasound is involved. Right. This is classified as a large vessel granulomatous vasculitis, itis, inflammatory. But it can affect vessels of any size. This is autoimmune in nature and it's inflammatory. A lot of things, as you know, if you've been following my presentations, a lot of tendinitis is actually tendinosis, so it's not inflammatory. This is something that is inflammatory. This affects those over 50, and the maximum incidence is 70 to 80-year-olds. It's a 3-to-1 women to men ratio, so women are more likely to have this. And more likely in Northern Europeans or Northern European descent. So think older, white woman, 70 to 80 years old is the most common group or high risk group. Okay, a correct and timely diagnosis is important. Some ER docs are using handheld ultrasound to screen for the disease. Where I'm getting this information is I was talking to the head of neuroimmunology at the University of Kentucky Medical Center, and he was shopping for handheld ultrasounds for their emergency department. And I thought, well, if emergency doctors are doing this, then I should also share this with other health professionals that may run into people with headaches and may run into people with this problem, and they can screen for it. So not just emergency room doctors, but other doctors that have access to ultrasound can also screen for this if it's easy to screen for. And you know what? It turns out it is easy to screen for. So much easier to screen for this than to check for a supraspinatus tear, for example. Timely diagnosis is important because you want to administer, corticosteroids, turn down the immune response, and to prevent sequelae such as irreversible vision loss or stroke. Right? These people can lose their vision or die. Most frequently, it affects the cranial branches of the external carotid artery, such as the temporal arteries or the occipital arteries, and the ophthalmic branch of the internal carotid. Right? Hence the blindness. Headaches with temporal tenderness are sort of the classical signs, but approximately 20% may not have a headache or may present with eye issues instead. In fact, let's go through sort of a list of clinical features. Right, elevated ESR or C-reactive protein, 90 to 95% frequency, headache, 70 to 90% frequency, polymyalgia rheumatica, 40 to 60%, constitutional symptoms, fever, fatigue, weight loss, 30 to 60%. Here's that, tender temporal artery, or diminished pulse, absent pulse, tender, 30 to 60%. Yeah, so if I'm just going by tenderness here and headache, maybe I'm missing 20% of diagnoses. Jaw claudication, 40 to 50%. How many people come in with jaw problems do I just work on the muscles and I don't check their temporal artery? I honestly, I do not end up checking their temporal artery, although I do check the temporalis muscle. So I probably would discover a particularly tender temporal artery there. Scalp tenderness, 33 to 50%. Visual disturbances, transient or permanent, 20 to 50%. And cerebrovascular accidents, TIA or stroke, 3 to 7%. So you can see this presentation is typically for people taking my program, so people interested in musculoskeletal ultrasound or wanting to become experts in musculoskeletal ultrasound. So if you're seeing people and you're imaging them for musculoskeletal ultrasound, who is coming to you? People with body pains, people with headaches, people with jaw problems, right? Chiropractors, physiotherapists, orthopedic surgeons. So I think this is a useful tool to use your ultrasound to help screen for and help diagnose giant cell arteritis, right? Now, the American College of Radiology, the ACR, have some diagnostic criteria. And so here's their diagnostic criteria. There's 5 of them. Age at disease, they're above 50. Do they have a new headache? Is there something, an issue with the temporal artery, such as tenderness to palpation? Elevated ESR, and then, of course, the abnormal artery biopsy, showing mononuclear cells or granulomatous inflammation, usually with giant cell infiltrates. So there's 5 criteria, and it's considered sort of positive meeting this criteria if at least 3 of the 5 criteria are present. If you meet 3 or more of the criteria, it has a sensitivity of 93.5% and a specificity of 91.2%. That's pretty good. Now, in terms of a singular test, temporal artery biopsy, sometimes just referred to as TAB, has been the gold standard for a long time now, but ultrasound is now recommended. So this is level of evidence 1, level of agreement 90%. This is very good for a recommendation that temporal and or axillary artery ultrasound is recommended as the first imaging modality in cranial giant cell arteritis, assuming high expertise, appropriate equipment, and prompt availability. Now, when compared to the ACR criteria, the ultrasound halo sign has a sensitivity of 43 to 77% and specificity of 89 to 100%. So sensitivity, not great, but remember it can affect multiple arteries, and you're just checking, one, right? But specificity is very high. If you find it, it's most likely that they do have giant cell arteritis. Now, there's another sign that you can look for with ultrasound. Instead of the halo sign, you can look for something called the compression sign, which is basically the same thing as when you're checking for a DVT, a deep vein thrombosis. In deep vein thrombosis, if there's a thrombosis, you can't collapse the vein. With giant cell arteritis, the artery is itself, the walls are thickened, and you can't compress the artery. And it's very, very simple to do, simpler than the halo sign. Very high inter-observer agreement, and has a positive predictive value as high as 100%. So even if you aren't doing the halo sign, which can be a little tricky, I highly recommend screening with the compression sign. Much easier to do. Now, in terms of a flow chart here, let's say you have your GCA clinical suspicion and it's low. Like, this person might not have it, but I have my ultrasound out. Let's take a look. Okay, you get a negative. Okay, you're not going to send them for an artery biopsy. Now, inconclusive or positive. Well, then you're going to send them for a biopsy, and or you're going to send them for to get an ESR or C-reactive protein, which would, if positive ESR, and that would bump you up to high clinical suspicion, perhaps, right? High clinical suspicion if you have tender temporal artery and ESR, that bumps up to high. That's already 2 out of 5, right? And then you can do your ultrasound, and then even if negative, you can then send them for the biopsy. And if it's positive, no need for the biopsy if you already have high level suspicion. Remember, positive, this thing has close to 100% specificity, so getting the biopsy might be redundant. Now, to check the temporal artery, you're going to need a high-frequency linear probe. The artery is very shallow. We're talking like 1 centimeter deep. So you don't need to see very deep. So this is not curvilinear. This isn't a mid-frequency linear probe. This is a high-frequency linear probe. Ideally, you have something 15 megahertz, 18 megahertz, 21 megahertz, because this is shallow and you want to get as high resolution as possible, so you want as high frequency as possible. Instead, 10 megahertz, 10 to 12 megahertz may give you high enough resolution to make a diagnosis. May, although you may end up with a lot of inconclusive images. Now, the walls of the artery will appear thickened and hypoechoic. Now, the signs we're going to talk about should be visible in both planes, but short axis is more common and arguably more useful. Now, a lot of research papers like to put images of the long axis because the long axis is, in my opinion, prettier. It's neater to look at because the short axis is just a circle. It's boring. But in terms of diagnosis, you want something that's easy to look at, easy to diagnose. You want something a little boring. The issue with looking at long axis is these arteries are typically tortuous, meaning that they curve and they bend and twist, and it's hard to keep your transducer in long axis to it because it's going to go in and out of the image. So I wouldn't really focus on long axis images. I would focus on short axis because that's easier and more useful. You can look at both the halo and compression signs in short axis. You don't have to worry about the artery coming in and out of the plane of view. And the halo sign, what is the halo sign? The halo sign is when you see, with Doppler, that the entire vessel is not filling. Right? There's a hypoechoic halo. What's the hypoechoic halo? The hypoechoic halo is the vessel wall. The vessel wall is normally very thin, and so if it's thickened, you'll see pulses of flow that don't completely fill the vessel. So here we have a case, and here's that thickened and erythematous and tender temporal artery. And this is going in long axis. When I imaged myself to practice, again, long axis didn't find that useful. I would go basically perpendicular to this, and actually you could follow this. So I could go perpendicular here and follow it up. And the artery, there's a vein that follows closely with it, and the vein will be more compressible than the artery. And so make sure you don't mistake the vein for the artery or vice versa. And so here you can see there's some pulses with this person has color Doppler turned on, and it's not filling the entire vessel. Now remember, you may have to tilt this so that Doppler will work. Remember that the flow has to be coming towards or away from the transducer. We can't see here because of the cropping, but this person probably has the little box tilted so that there can be flow towards or away the transducer. Because if there's no flow towards or away from the transducer, color Doppler and power Doppler won't do anything for you. Right, so either heel toe the transducer, or in the case if you're looking at short axis, tilt the transducer, make sure there's an angle to it so that the flow can come towards or away from the transducer. Right, and if you're following that, then you should see some pulses in the transducer, and then you can use. Typically, your transducer your unit will have a feature where you can freeze and then go back frames. So you can go forward and back in the frames to see how full the vessel fills, and then you can measure the thickness of basically this halo, and you can use cutoff values. Again, I wouldn't really do this in long axis. I would do this in short axis because it's just easier. And there's a range of proposed cutoff values for the halo sign. 0.3 to 1 millimeters for the temporal artery, and for the large intracranial arteries, it's 1.3 to 2 millimeters. So you may want to ask me, Brandon, why are you giving me a range of cutoff values? Just give me one cutoff value. Like, make it simple, make it easy for me. Well, A, there's a range. No one's agreed on just a singular cutoff value. B, a range of cutoff values can be useful. It's useful to get a collection of information. So when I see a range of cutoff values, I think, okay, 0.3 to 1 millimeters. This means if it's less than 0.3, it's most likely normal. If it's in between 0.3 to 1 millimeters, well, that could be, giant cell arteritis. And if it's greater than 1 millimeter, oh, it's almost definitely giant cell arteritis. And you can convey this in your charting as well. Right, it's 0.5 millimeters, which increases my suspicion for giant cell arteritis. This meets some of the proposed diagnostic criteria for the halo sign, but it's not in agreement with all cutoff values. So, like you can say this increases suspicion. The compression sign is when you fully compress the artery. If it doesn't fully collapse, then that would be a positive. If it collapses fully, then that would be a negative, right? I expect here, if I were to try to, let's say, collapse this artery, I would expect, this part and this part not to collapse. So the artery is still going to appear thickened. It will still be this hypoechoic structure even when I increase pressure. Now remember that there are veins nearby, and the veins should collapse here easily, so don't mistake the veins for arteries. And arteries in general are more resistant to compression, so you have to apply a little bit more pressure to get arteries to compress compared to veins. Now there are some problems with the halo sign. And those problems come from atherosclerosis, other vasculitis, infection, malignancy. There are other things that can cause the halo sign. So you can end up with a false positive. And one solution is you can look for more vascular territories, quantity of halos, look for other arteries. You can use higher cutoff points. Right? If you do use a cutoff point of 0.3 and 1.3, you're more likely to get more false positives. Right? And false negative is learning curve. You're using the wrong probe, wrong technique. You haven't practiced. You haven't looked at some normals. My goodness, practice, practice, practice. Okay, so here is a short axis. This is how I tell you should do it. And here we have it with the color Doppler, and we see a signal here, and we can see the halo around it. So this is halo sign. Remember, for color Doppler to work, you may have to tilt the transducer so you have flow towards or away from the transducer in order for Doppler to show you anything. Now you would think this is just the color Doppler turned off, but that's not the case. This is actually with the compression test. So with the compression test, the vessel's still there. It doesn't collapse. So this is a positive compression test, and this is a positive for the halo sign. Now this is myself, so this is normal. So there is my temporal artery, and so this is no compression temporal artery, and I'm using power Doppler here because it's more sensitive to flow. And the artery itself actually increases in size. It pulses, which sort of makes sense, and the flow fully encapsulates the entire artery. So I definitely do not have GCA, or at least based on this. Now I did try to look at the artery with my cheaper ultrasound. So the one I showed you before was a 15 megahertz ultrasound, and this is 10 megahertz, and it's a cheap Chinese probe. The cheap Chinese probe, I had a bit of an issue with the power Doppler and color Doppler. These cheap Chinese probes, the frame rate, it just drops down to like 1 frame a second. It's terrible to use. But I feel I can still see the artery, and I could still do the compression sign. So I don't think a lower frequency, even a cheap lower frequency, but still relatively high, 10 megahertz isn't that low, is still useful for screening. Although the higher frequency, you can look at how much higher resolution it is. Now, these arteries will be larger in someone with these issues. And just to give you a sense of scale here, this whole scale is 1.4 centimeters. This here is a little larger than 1 millimeter. 1 millimeter. So 0.3 millimeters, 0.3 would be 0.3, 0.3. That would be at least half of this would be. So if I would try to compress this, and only half of this would compress, and that would meet like the minimum criteria, right? So this is a very small scale here, and look at the resolution, right? I could compress and see if that compresses or only compresses halfway. I could do that. So 15 megahertz, I think this is plenty, and this is just a handheld ultrasound unit. So we are at an understanding check. This one is short answer, and this one's pretty simple. How would you check for giant cell arteritis? See if you can remember. What type of probe? How should you position the probe? What are your actions? What are you going to be doing with the probe? This is so much easier than evaluating a shoulder or evaluating a knee, in my opinion. So hopefully, this tests your understanding. Now you can pause the video. In about 5 seconds after I finish talking, my solution will be shown.